Hello, everybody. Thank you for joining me here today. My name is Fabiana Bacchini. I'm the Executive Director of the Canadian Premature Babies Foundation. Every Monday and Friday, we are doing Facebook Lives, bringing experts from all over Canada and parents to share their experiences with the pandemic, but also to share their knowledge and expertise in many aspects of prematurity. And today I have here with me Dr. Sarah Macdonald, who is a maternal-fetal medicine specialist, a high-risk obstetrician, and professor in the Department of Obstetrics at the MacMaster University here in Ontario. Her research as a clinician-scientist is supported by a prestigious Canada Research Chair. Her research focuses on preterm birth, and that has informed several national guidelines from the Society of Obstetricians and Gynecologists of Canada. She co-leads the Canadian Preterm Birth Network, funded by the Government Health Granting Agency, the Canadian Institutes of Health Research, CIHR. Dr. Macdonald, thank you so much for joining us here today. Such a pleasure to have you. And I know how busy you are during this pandemic.
Oh, Fabi, thanks for having me on this Facebook webinar. I'm so thrilled to be here. I'm delighted to have the chance to connect with you again and with other preterm birth parents. So thank you very much.
Thank you. So I'm going to start by asking you, why are reasons women deliver early? Because obviously for us involved in this work, it seems to be, okay, we all know, but there's a lot of women who are pregnant who have no idea why prematurity can happen to them.
That's such an important question, as you said, so we can all be educated about it and know when to present if we have symptoms, Fabi. So there's three main reasons why women deliver early. And one has to do with things like health conditions, medical conditions that require early delivery. A second large category has to do with women who their membranes rupture early, called preterm premature rupture of the membrane. And the third group are a group of women, for whatever reason, begin to contract. Their uterus begins to contract too early. So those are the three broad categories for why women might deliver early, and each has multiple reasons within it. So for example, women might start to contract early because their uterus is stretched more because they have twins or triplets or higher order multiples, or they might just start to contract more for reasons we don't know why they start to contract early. But each of those three broad categories, like I said, has a number of different causes under it. So for example, on the first one that I mentioned, medical indications for early delivery, preeclampsia would be a common cause. So women who develop high blood pressure during pregnancy, and that can start to make them or their babies very ill. Another medically indicated cause would be sometimes the baby, for other reasons, not preeclampsia, is very small. And so the conditions in the uterus are such that it's better to have baby delivered than to remain in the uterus. So broadly, three main categories. One is medically indicated, a second is early rupture of the membrane, and a third is spontaneous contractions for reasons we often don't understand.
So, but you've done a lot of research and on prevention of preterm birth. I was always fascinated to learn from you what is being happening in that field. So what do we know so far that can possibly prevent preterm birth?
The way we prevent preterm birth depends a little bit on what we think is the cause of it. So for example, for women who have multiples or more than one baby that they're pregnant with at a time, if, for example, they were undergoing fertility treatment, if we could help them to have one embryo transferred back in circumstances where it's warranted. There are certain circumstances where the fertility experts recommend more than one baby be transferred back, more than one embryo be transferred back. But trying to have as healthy an environment every pregnancy, I think, is the goal for mothers, fathers, healthcare providers. So for example, in circumstances where a woman's undergoing fertility treatment, if we have as small a number of embryos as possible that will help her to have the best outcome. So each circumstance is a little bit different because women and families are different, and how we would approach preventing preterm birth, I think, should be tailored for each woman and each family. In cases, for example, where a woman has a history of just starting to contract early for what we call that spontaneous preterm birth, then a medication called progesterone, we have found, has been very effective at decreasing that risk of an early birth in the next pregnancy. And that medication, progesterone, can be started from 16 weeks onwards of the pregnancy. And we know it decreases by approximately half her risk of having an early birth next time, or of having an early birth in which the baby passes away. So it's very impactful when a woman has a history of preterm birth, or when she has a short cervix during this pregnancy. So sometimes we monitor the length of the cervix with ultrasound. Usually transvaginal ultrasound is the best way to do that. And if we see a short cervix before about 24 to 25 weeks of pregnancy, then we will often start a woman on progesterone to try to decrease that risk of preterm birth. And it's a very powerful medication for that. And thankfully, I've gone a long time in my career, almost 20 years, before I had a medication that I could use to help women. And so we were very excited when we found that information. There'd be other ways that we can help women to have the healthiest pregnancies. So for example, if a woman has a history of preeclampsia or has certain risk factors for preeclampsia, and I know you were speaking with Dr. Kingdom recently, and he's a great expert on that, so I won't spend too much time on it, but I always like the chance to reinforce that aspirin started after 12 weeks of pregnancy, and we usually recommend 2 baby aspirin at nighttime. Also significantly decreases the chance that the preeclampsia would return in a subsequent pregnancy. And it's also been found to be useful for preventing a small growth in babies that's coming from a placental problem. Small growth can happen for a variety of different reasons, but when it's felt to be due to a placental problem, those 2 baby aspirin at night, taken from 12 weeks onwards, also help to prevent that reoccurring. So we're starting to build up different treatments, finally, that we can offer to women. But I think each one should be tailored and should involve a discussion between the woman and her care provider, so that we can ensure that we've got the right treatment for the right woman.
Absolutely. But when you talk about the medication, the research showed this is safe for the baby.
Mm-hmm. That's right. Both those medications that I've mentioned, progesterone and aspirin, have been found to be safe. But we recommend starting the progesterone after 16 weeks of the pregnancy, and the aspirin after 12 weeks. The aspirin in particular, if it's taken before then, has been associated with a small increase in certain structural defects or birth defects in the baby, but after that 12-week mark, it's felt to be safe.
Sarah, but going back a little bit on prevention of preterm birth, we had talked about a lifestyle, women's lifestyle. And I think this is something that we could all learn from that. What are the lifestyles are you talking about? What should that lifestyle be? Because right now, there was an interesting study that came out of Ireland saying that in Ireland that the preterm birth is declining during the COVID, and there was a speculation is because women are less stressed. We don't know if that's true or not, but how do you think the lifestyle helps to prevent preterm birth?
That's a really important question, because I think that we want to address as many different aspects as we can to help women have as healthy a pregnancy as possible, and that includes lifestyle. Thank you for sharing that article with me about Ireland's decrease in the rate of preterm birth during COVID. That was exciting to me to see. It was interesting. I'm not sure they know all of the reasons why, but one of the hypothesized reasons is that less stress, less travel time, less exposure to other illnesses because people were staying at home correctly. I think stress is an important factor. I wish I could write myself the no stress prescription, and I'd write it for myself and for all of my patients. But managing mental health challenges is important for all of us. And we know that, for example, anxiety and depression during pregnancy impact they increase the risk of preterm birth. So finding healthy ways to manage mood is really important. For some women, that is through things like yoga or exercise or therapy with a counselor or medications. It varies, and each woman, I think, again, this is an area that we need to tailor for her in particular so that she's as healthy as possible. For some women, medication is really important. And in those cases, we recommend that the woman stay on the medication or start the medication if that's the recommendation from her specialist. Because if a woman is really ill with depression or anxiety, then she can't be healthy and the pregnancy won't be as optimally healthy as possible. So I'm really glad you started with stress and thinking about mental health, because that's something that I think is pretty common to many of us, all of us, particularly during COVID, is mental health challenges and being healthy and finding healthy ways to handle our stress. Some other things that I think are really important in terms of lifestyle are what we put in our body and what we do with our body. So avoiding certain chemicals that we know increase the risk of preterm birth is always a good place to start. So for example, we know that cigarette smoking, marijuana use, alcohol use, and certain other street drugs, in fact, most of the other street drugs, increase the risk of preterm birth. And so I would just encourage any woman to share that information with their care provider. It's confidential, it all is confidential, and to have a dialogue about how can we manage if there are those chemicals involved. For some patients, they are able to remove them completely and to quit. And for some patients, they're able to reduce. And reduction is an important step forward. And I applaud and celebrate with my patients when they're able to do that. Complete elimination isn't always possible of some of those chemicals, but reduction is a really important first step and a good place to start celebrating if a woman is able to do that. There's some other lifestyle issues that can impact a pregnancy. So starting the pregnancy at as healthy a weight as possible, because we know that both underweight and overweight increase the risk of preterm birth. So if a woman in conjunction with her healthcare providers can start the pregnancy at as healthy a weight as possible, that's an important starting point. Gaining weight in a healthy way is also important because, again, undergain and overgain have both been associated with an increased risk of preterm birth as well as other complications. So we know that women need to gain weight typically to have a healthy pregnancy because you are growing another human being, and that weight gain is important for most women for that. I think tailoring that weight gain again is really key. And there are guidelines that have been put out by the Institutes of Medicine and endorsed by Health Canada about healthy weight gain. And I'd encourage women to bring that up with care providers. We know that sometimes care providers are reluctant to address weight and weight gain because we don't want to make any woman, underweight or overweight, feel stigmatized about her weight. I would hope we could help her to feel empowered about gaining a healthy amount of weight during pregnancy. But if your care provider doesn't bring it up, please bring it up. It is an important predictor of how the pregnancy develops. And again, we know that care providers are a little bit reluctant sometimes to address weight, which is interesting because in a study, we found that 84% of women were either comfortable or very comfortable discussing weight with their care provider. So this might be a bit more on our side, the care provider side. Of course, we should address this in a sensitive manner because sometimes weight is a sensitive issue for women. But it's really important that women have the right information about how much to gain for their body type. Exercise is something that typically goes down during pregnancy. Sometimes that's for obvious reasons because your balance is off, you're tired, your joints are looser. So during pregnancy, we recommend that women take on new exercise in a gentle, gradual way and in conjunction with their care providers. But for most women, exercise is an important component of having a healthy pregnancy. And I always like to tell my patients at the end, especially first-time moms, well, you're going to push, and you may push like you're really pushing hard, like as if you're pushing a truck out of the ditch. And you might do that for a couple of hours. So we want you to be healthy before you do that. And I also find exercise is one way I keep my brain healthy, that I manage my stress. Again, we recommend this is done in conjunction with care providers, because there are certain women we recommend don't exercise. So, for example, if your cervix was dilated and membranes were visible at an early stage in the pregnancy, we wouldn't recommend that that woman exercise. But there's lots of kinds of exercises that can be done in a healthy way during pregnancy in conjunction after communication with your care provider. So lifestyle, both mental and physical, is really important to having a healthy pregnancy.
Absolutely. Thank you, Sarah. You touched so many important points, and I'm always fascinated to talk to you because you really also talk about the stigma of mental health, the stigma of women who are, have addiction. And I think this is such an important conversation that you have to have. I think this is the only way you can all feel comfortable talk about issues that really matter and can help women and obviously and their babies and their families. So I want to ask you, besides obviously some medical conditions women already have and the lifestyle and the weight, what could put women at a higher risk of a pregnancy? Because sometimes you feel like you're very healthy, you're young, or maybe like me, I was at almost 40 when I had my second pregnancy, but I was very healthy. I struggled with fertility for many years, but I had no other health issue. But the twin pregnancy did put me at a higher risk. I was also 40. I also had an in vitro pregnancy, so that I didn't know I was considered higher risk right away. But is there any other conditions that can put women in this higher risk?
Yes, there are. So for example, having a short interval between pregnancies. If you've had one delivery and there's less than about 18 months between your next pregnancy, we know that that increases the risk of an early birth. And that's one piece of information that's really important that we communicate to women, because obviously if you have an early birth and your baby's in the neonatal intensive care unit and your life is chaotic in a way that probably none of us have experienced until we go through that, things like, you know, maintaining good health for yourself, including birth control, often isn't the priority, understandably. It's also perhaps not that well known, or care providers are sensitive about addressing spacing of pregnancies with women. But that's one important thing, is that allowing adequate spacing for reasons we don't completely understand, but we know that the shorter the interval, that increases the risk of an early birth. So that's one factor. Some things you talked about, our age, we can't really change. I used to say advanced maternal age, and when I passed 40 a long time ago, I started saying wise maternal age. We can't modify that factor. So there are certain risk factors that are part of us as our human beings at that stage in our life, and that we don't have control over, and age would be one. In terms of other factors that increase risk, so one of them is this early rupture of membranes, that we know that if the membranes rupture early, that increases the risk of an infection, and that often triggers labor. And so trying to prevent that membrane rupture is important. Unfortunately, we don't have a lot of good ways that are proven by science for preventing that. But once a woman has a history of that happening, then screening for certain bacteria in the first trimester and treating those may decrease that risk in that current pregnancy. We talked about lifestyle modifications. We talked about the use of certain medications as well, and mental health supports. Those are a lot of the main ways that we can help to prevent early birth, as well as things that we've touched upon, such as having ideally one baby at a time, or not quads or triplets if that's possible. It's not always possible. One fact of life is that as our age goes up, our risk or our chance of having multiples goes up as well, whether we use fertility medications or not. And so that if we could adjust society so that women had more supports to have childbearing at the time they wanted, as opposed to sometimes deferring that for career or other reasons, I think that would be really important on so many levels, but perhaps out of the scope of our half an hour talk today.
We can have a whole Facebook Live on that for sure. But I want to talk to you, once you are, your doctor say, yeah, you are high risk of delivering prematurely, whether it's at 22 weeks or later, preterm. Are there specific steps a woman should take to help her to stay pregnant as long as possible, if it's when possible?
Mm-hmm. Addressing all of the factors that we've talked about so far, including having regular healthcare visits, is very important. I think for some of my patients who've had an early birth, they're really scared to come to the doctor again. And sometimes even coming into the building is traumatic, because this was the building where things didn't go the way they had always hoped. And I recognize that, and I think that's common across many, many different facilities. It's not just my own at McMaster. We had a day-long meeting with parents last fall. It happened to be at the Hydro building at Mount Sinai. And I asked some of those parents, is this a difficult place to be? And they said yes, because it was in the Hydro building that they were told they were going to need to be hospitalized, for example, et cetera. So I think we need to be sensitive to that. And sometimes if there's a possibility, I have patients who are halfway between here and could be served at Mount Sinai. And if they've had a difficult time, at either one, I think we need to think about being flexible about where is the least painful place for them to get care, so that it's not traumatic every time they walk into a building, and that we're not revisiting or re-traumatizing patients. So I just really encourage patients that, if coming into this space with their care provider is challenging, many of us have colleagues who would be willing to see them instead, et cetera. And it's not taken personally, right? It's just sometimes for some patients, being with the same care provider is challenging, and that might be why they're holding off from seeking care. It's really important that we get the message off that early care, we know, decreases the risk of preterm birth. And women who are unable to seek that care, or for any variety of reasons aren't able to attend that care until, for example, the second trimester, their risk of preterm birth goes up. And particularly in women who've had an early birth before, those are the women we want to help the most to have early care. And we need to be flexible about that. And I would ask women to feel empowered to say to the care providers, you know what, not you, but I can't come into this building again. It holds too many painful memories for me. And then the care provider could work with them to find alternate solutions for care. So care is really important. Finding the right setting for that, I think, is also equally important. I would encourage women who've had an early birth or who have significant risk factors to have at least a consultation with an obstetrician or a high-risk obstetrician. My family medicine and midwifery colleagues do a fantastic job of low-risk care and supporting women who are in high-risk care as well. But I think the medical care for women who are at increased risk of preterm birth should be with an obstetrician, potentially supported by family medicine or midwifery or other services, but under the care of an obstetrician or a high-risk obstetrician. We want the right care for the right woman, tailored for her. Once a woman starts to feel symptoms, and maybe I could spend a moment talking about those symptoms, Fabi, and then I'll circle back to once she starts to feel that, then how can we prevent preterm birth? One of the things we would encourage patients is and I always say to patients is don't angst alone at home. If something feels different, you know your body, call us. Call your care provider and describe what you're feeling. And sometimes that involves you coming in and getting checked out, that we see is your cervix starting to change or not. So what would be some of those symptoms? Let's start with, for example, spontaneous early birth. That often starts with symptoms of period-like contractions or that kind of ache in the pelvis when you're about to get your period. Sometimes that's all it is for women. Sometimes it's a new and a different pressure. However, in many women, those kind of mild pressure feelings start to build in intensity and come out of just a deep ache in the pelvis to more a lower tummy, lower abdomen or tummy ache. Sometimes low back pain comes with that. And it's often a pain that kind of comes and goes. And then one begins to perceive irregularity to it. Oh, it's coming every maybe 20 minutes. And then what's particularly concerning is when that time interval shortens and it was coming every half hour, every 20 minutes, and then it starts to increase even more in frequency. Sometimes then women notice their tummy gets tight and relaxes. And sometimes that's with pain or without. And that, again, develops a kind of cyclical or a regularity to it. And all of those symptoms one should seek care for, because we sometimes after we check a woman and know that her cervix is not changing, then we send her home and we say, you know what, the good news is the symptoms you're feeling right now haven't changed your cervix. But we always put a caveat of if this is not going away or if it's getting worse, please come back and see us. Because when we check somebody and we examine them physically, we know at that moment what her cervix is doing. But neither she nor I can predict if the symptoms were to go on, what would be the impact on her cervix. And the only way we can know is to have her come in and get checked out.
And I think this is so important because if it's your first pregnancy, you don't know anything about pregnancy, right? You read in books and it's okay, this is a normal contraction or preparing for labor later on. But we don't really know what it is, right? Because you're fresh. Obviously, if it's the second pregnancy, you kind of, okay, I know this is off. It's not quite right. But I think it's very hard for a first-time mom.
I agree. There's a lot changing during pregnancy, isn't there? I mean, your body is being revolutionized. It doesn't feel the same. It doesn't look the same. It doesn't react the same. And so I think it is very difficult for first-time moms, and even many of my moms who've had, you know, multiple pregnancies tell me, this one's not like last one. The number of times it feels different is fascinating to me. And I think there are certain things we just can't determine by trying to sort out those symptoms on our own. And at the end of the day, I have to check a woman's cervix to know, is it starting to open or not? That's the only way at the end of the day I can feel certain, okay, you know what, good news, it's whatever symptoms you were having, it's not impacting your cervix. So we know it's safe for you to be home now, but if things change, you have to come back to me, right? Or if they're not resolving. And so I think you're right, it is challenging, and women shouldn't have to sort that out on their own. We'd far rather see a woman, talk to her in detail about what the symptoms are that she's feeling, check her cervix, maybe put her on the monitor, see if we're seeing uterine activity on the monitor, etc. Do all of that assessment. And women shouldn't have to figure that out on their own because they can't see their cervix. So they can't know if it's changing.
Right. And I think even it's an important message, even now during the pandemic, that people are more afraid of going to the doctors and to the hospital. It's just as important of going and having that follow-up or one phone call for the doctor doing an assessment, okay, come into my office, or give some advice to the woman. And I think it's not a time for us to forget everything else that is happening because of COVID. Is just as important.
Absolutely. Absolutely. And happily, I think for many of us, we work in regions where the rates of COVID were are falling, and we're not as high as we were concerned they might be, but you're absolutely right. And it's really important to stress that, Fabi, is, you know, if you're having symptoms, please come get checked out. The hospitals are taking extra precautions. You'll be screened at the door. You'll be given a mask. We're using lots of hand sanitizer. You'll be met by people wearing masks, all of whom have been screened as well. All of the healthcare professionals in the building have been screened. So please come in if you're worried.
Absolutely. So I want to go back to mental health, because this is something that you and I will talk a lot about when we meet in person or over your research projects. And you mentioned mental health before during the pregnancy and why it's so important to address that, because I feel that a lot of women are giving information about postpartum depression. When you go to our obstetrician, there are signs all over the hospital about the, ask me about the baby blues. And so there's so much focus that I feel that is for postpartum depression, even though we still have a lot of work to do on that front as well. But why it matters to take care about the mental health while women are still pregnant, thinking about if she's going to deliver earlier in the ICU period and moving on. And I think that is something that we don't talk about enough, the mental health part from pregnancy, moving on to an ICU stay and after discharge.
I agree, Fabi. I think, and just as you said, we're not trying to take away the emphasis on the postpartum period, but also recognize the importance of during pregnancy. And you said, why should we care? Because it's suffering that's real, just like physical suffering. So if you cut your hand and you were bleeding, I would try to help you. And if your brain is hurting, I want to try to help you too. Because that is every real, the pain from mental health challenges as physical. In fact, sometimes one might argue worse. So if we care about the health of people, I think we care about the whole health, mental and physical. That's my main reason for thinking why we should address it during pregnancy, is so we can help people feel better and hopefully suffer less. The other reason pertinent to this webinar is that we know that mental health challenges increase the risk of preterm birth. So helping women during pregnancy to be as healthy as possible mentally and physically is really key. The third reason is that we know that after birth, particularly if baby is born very early, mental health challenges are naturally more common in parents. We've studied women more than men. I mean, not me personally, but across the spectrum. Fathers are often called the forgotten parent. And you and I both feel that's something we are working on to try to correct, to bring dads more into the picture and into the research picture as well. But we know that when your baby's critically ill in the neonatal intensive care unit, and particularly when those babies are born very, very early, that is a trauma that, as you know better than most people, Fabi, and can speak to certainly better than I can, but that trauma is repeated often over and over again on a daily basis for months, potentially. And we know that repeated traumas increase the risk of long-lasting impacts from a mental health point of view. And so for all of those reasons, not the least of which that we don't want to be having mental health challenges go unaddressed and then surface in the postpartum period after an early birth. We want that woman supported along the continuum of care from, you know, preconception through pregnancy, through hopefully not in an ICU stay, but if that's the course that happens, then we need to support mothers, fathers, I think, and families, you and I have talked about, along that whole continuum, including after discharge from the NICU.
Absolutely. And I think this is something that we have to really spend time talking about, doing something about, and make sure those families don't feel alone. And I just did an interview with Dr. Andrew Hollett. He's a psychiatrist who created Father's Mental Health Program in Ontario, and it's phenomenal, and so much about dads that we still don't know, and we still have to learn and help dads as well, because as you said, they're always on the back seat of this, and we are looking at family, right? It's a holistic being, not only the mom or just the baby, it's the whole family context. So also always very important to talk about. So just for us to finish it up, are there supports available for families who are pregnant, who are facing mental health issues, or who are at risk of delivering prematurely, that can have some mental health support while still pregnant to what is coming, she's going to face? Because I remember having support from psychiatry when I was pregnant with my twins, and I knew one of our twins was going to pass away, and the hospital offered me to see a psychiatrist. I saw a few, I had a few sessions, and it really helped me to get through the pregnancy until I delivered earlier. So is there this resource available? I know you're in Ontario, but do you know any resource that families can access across Canada, or is a matter of just talking to the physician and ask for help?
I think starting with the physician is a really important place. The physician may refer you, your own primary care provider, be that an obstetrician or a family physician or a midwife, may refer you on, but it's really important that people be encouraged to bring this up with care providers and say, I'm struggling, this is painful for me, I'm having some challenges. We want to help just like we would if your hand was bleeding. We want to try to help, and those mental health challenges are every bit as real and every bit as painful as physical suffering. Sometimes it's out of my own area of expertise, and so I do need to reach out to my colleagues, and I need to get my patient the best care she can, and that's not usually me if it's a mental health challenge. I want her to go to the expert in mental health. So for example, there are programs in my area that support women's health, and I happen to know those. I don't want to address too specific, I don't want to talk about Hamilton, because I know that your reach is across Canada, and that's fantastic. But each care provider will know the services in their region. Sometimes that involves starting, for example, with social workers. We have a great team of perinatal social workers who bridge from the antepartum period, intrapartum, postpartum into the NICU. Sometimes that involves psychologists or psychiatrists, as you mentioned, and each of us know the resources in our region. So I would encourage women to reach out to care providers and ask for those supports. There's no shame in this, or there shouldn't be shame. We need to break down that shame that is often associated with mental health challenges that seem to be different than physical health challenges. Pain is pain. Let's address it. And so I applaud women for having the courage to come forward. If they don't feel they can talk to their care provider, there are a lot of good resources online. So the first place I always refer people to, as you know, is your own website and your own group. I think knowing you're not alone, knowing there is actually a parent someplace in Canada who's walked that very similar path, who understands in a way that almost nobody else can what you're feeling, is a tremendous support. And I know my patients whom I've said, just approach them, they'll let you into the Facebook group, and you'll find unbelievable support there. And I've heard that time and again from patients. So I would say reach out to the CPBF community. They want to support you, and they want to help you feel less alone. There are also a number of mental health resources online, and different centers, for example, CAMH in Toronto has a good website with different resources. Sunnybrook has a website with a lot of good resources. So one great thing about the internet is it's making the world smaller, and also allows many patients to access some of those, for example, resilience training, mental health challenges, relaxation, that one can do in the privacy of one's own home, which in the setting of COVID, one doesn't even have to leave. But also for women who don't feel that they can mention this to their care providers, it's a good place to start. But I would recommend that they do reach out to their care providers, because we want to help patients through mental and physical health challenges.
Absolutely. Dr. McDonald, thank you so much for joining us here today. I know we can talk forever. There's so many things that we can touch and expand on, and I will invite you to be back so we can talk about a second pregnancy or third pregnancy after having a loss or having an ICU stay. I think it is a very important issue that we touched today, but we didn't have time to go in depth, but I think it's something very important for our family. So thank you so much for taking the time to talk to our families today.
Oh, thanks, Fabi, for the chance. This was the highlight of my week. I hope it helps some of your families, and congratulations on the tremendous work you and CPBS are doing. And thank you for always saying yes when I ask you to partner on research so that we can have research that matters and is important and is addressing questions that are important to parents.
Absolutely. Thank you so much. And thank you everyone for joining us here today. Every Monday and Friday, as I mentioned before, 1 p.m. Eastern time, we're going to be bringing experts and families to talk about issues related to prematurity and also the COVID-19. And every Wednesday at 1 p.m. Eastern time, Kate Robson, who is a psychotherapist and also a mother of two premature girls, is hosting real-time peer groups here on Facebook. And to join her group, you can join the Canadian Preterm Birth Network, which is our private Facebook group. This is the peer support group that Dr. McDonald was talking about, that we have over 2,400 families across Canada really providing support to other families and providing local resources. So stay tuned in our social media channels for what's coming up next. Thank you so much and have a lovely end of the day.
Thanks, Debbie.
Bye now.